Here is the second part of the central nervous system problems on voiceover. So it's within the chapter of chronic neurologic problems, chapter 58 in your new edition. On page 1393, we're going to start with myasthenia gravis. So myasthenia gravis, maya meaning muscle, gravis meaning grave or terrible, a terrible muscle disease. It's a progressive autoimmune disease that produces severe muscular weakness. So people can have periods of exacerbations and periods of remission. Exacerbations are usually triggered by infection, stress, fatigue, medications, and heat. Basically, the pathophysiology of this is that it's an autoimmune process that antibodies attack the acetylcholine receptors. So that prevents the acetylcholine molecules from attaching and stimulating muscle contraction. The clinical manifestations of myasthenia gravis, your primary manifestation is fluctuating weakness of skeletal muscles. So progressively, there's, as the disease goes on, there's more muscle weakness going on. Poor posture, drooping eyelids, or also called ptosis, dysphagia, difficulty swallowing, double vision, and fatigue are other symptoms. So usually at the onset of the disease, only the ocular muscles are involved in about half of the patients. So sometimes there's bilateral ptosis, or the drooping of the eyelid, and constant or transient diplopia, or double vision. You can look at a picture on page 1393. The guy is displaying the peak sign with myasthenia gravis. You could try this sign on somebody. During sustained forced eyelid closure, he's unable to bury his eyelashes on the left, and then after 30 seconds he's unable to keep the lids fully closed. So he kind of doesn't close his eyelids all the way, but also the drooping eyelids is a key feature. Also, the muscles of the trunk and the limbs are less often affected. The proximal muscles of the neck, shoulder, and hips are more often affected than the distal muscles, or the ones further away. No sensory loss occurs. Reflexes are usually normal, and muscle atrophy, or the wasting away, is rare. The disease is variable, going back and forth between remissions. And some people have extreme exacerbations. So we'll talk about that on the next slide. So a myasthenia gravis crisis, or myasthenic crisis, that's also on page 1393, is an acute exacerbation of muscle weakness triggered by respiratory infection, surgery, or pregnancy, or some drugs that may have precipitated this event. The major complication of myasthenia gravis results from muscle weakness that it gets so bad it affects swallowing and breathing. So open airway is one thing you want to pay attention to. So that can result in aspiration and respiratory insufficiency, and even respiratory tract infections. So some other complications are listed here. Bowel and bladder dysfunction is a big one. The muscles of the bowel and bladder are not working well, and the decrease in muscle strength can result in a lot of falls also. So our diagnostic studies for myasthenia gravis, First in your book, it talks about an electromyography, which would just be like small needles inserted into the muscles that they evaluate muscle activity and may show some marked weakness. If you want to look at electromyography or EMG, it's also on page 1311 of your book. Also, I don't have it on the slide, but a chest CT might be done also to evaluate if there's any enlargement of the thymus gland. That is sometimes a problem with myasthenia gravis. The Tensilon test is a big one. Tensilon is an IV medication that we inject, and after it's administered to somebody with myasthenia gravis, there will be marked improvement in their muscle strength for 5 minutes after giving this medication. So that's usually positive for a diagnosis. So of course we want to have a baseline assessment done to know how much muscle weakness they have, and then give the Tensilon and then see how much improvement is done. So some treatment of myasthenia gravis could be drug therapy. Talks about that on page 1394. Anticholinesterase drugs are given to enhance transmission of the neuromuscular junction. Acetylcholinesterase is the enzyme that breaks down ACH. So inhibition of this enzyme by an anticholinesterase inhibitor will prolong the action of acetylcholine and facilitate the transmission along the neuromuscular junctions. So our cholinesterase inhibitor medications are our first line of therapy. They need to be taken at the same time each day to help maintain a therapeutic level. Also, on some patients, they might consider a removal of the thymus gland. Myasthenia gravis appears to enhance the production of anticholinesterase antibodies. So removal of that thymus gland results in improvement in many patients. So remember the thymus gland, it's larger when we're children and it gradually shrinks as we become adults. And it's thought to produce those T cells that we need for long-term immunization throughout our life. And eventually as we get older, it becomes like fatty tissue, but they think that has something to do with anticholinesterase antibodies. So that would be why they remove that. So some other therapies they might do would be like plasmapheresis. And that is just, especially if somebody was having a myasthenia crisis, they might consider this, as if they're in a crisis, they could stop breathing. So they're really wanting to do something immediate. So plasmapheresis removes the circulating anticholinesterase antibodies in the blood. So basically what that procedure is, it's a machine. We're removing whole blood through an IV, and then the blood's filtered in a machine that divides out the plasma from other blood parts. And then the plasma is replaced with either normal saline or lactated ringers or fresh frozen plasma or albumin. And maybe you've heard of them doing plasmaphereses with other diseases, some other autoimmune diseases, just to filter out those antibodies that's causing the problem. So our big intervention with myasthenia gravis are going to be maintaining airway, preventing aspiration. They're going to be really tired, and they seem to start out doing pretty good early in the day, but then gradually have more muscle weakness as the day goes on. So we do want to conserve energy and have frequent rest periods. We want to do daily weights and monitor their INO also. I also want to mention that many drugs are contraindicated with myasthenia gravis. So you might want to read on those because they react with the acetylcholinesterase process. Okay, our next disease we're looking at is amyotrophic lateral sclerosis, otherwise known as ALS. It's a progressive neurological disorder characterized by loss of motor neurons. So the motor neurons in the brainstem and spinal cord gradually degenerate for unknown reasons, and then the dead motor neurons can't produce or transport signals to muscles. So some signs of this disease is weakness and muscle wasting as the disease progresses. It happens more frequently to men, so it's like a 2-to-1 ratio from men to women. It is pretty rare. Death usually occurs within 2 to 5 years of diagnosis. The usual onset of this disease is age 55 to 75. This is also known as Lou Gehrig's disease. He was a famous baseball player that had this disease, so that's why they call it that sometimes. And a couple years ago, on social media, we had the ALS challenge. The whole purpose of that ice bucket challenge, was to spread awareness about the disease, just to educate people. I don't know that it really educated them on what it was, but everybody was talking about ALS all of a sudden. So a very sad disease. Just starts breaking down the muscles, and the muscles waste. Pretty much their whole body starts not functioning, but their brain, their cognition stays intact. So they know what's going on. So death usually does occur from respiratory infections. So it's the slowing of the ability to use the muscles, and that even includes the respiratory muscles. They may progress to where they can't even speak anymore. They may have to be put on a respiratory ventilator if they want to do that to continue breathing. I have taken care of a couple of people with this disease. Okay, Huntington's disease is also another rare disease. It's genetically transmitted autosomal dominant disorder. It affects men and women equally across races. The offspring of a person with this disease has a 50% risk of inheriting it. So genetic counseling is going to be very important with this disease. You can read in your book, they can also do tests to find out when you're pregnant. They can test to see if that gene is there for the Huntington's disease, which means they will get it eventually in life. That's not necessarily a diagnosis, but there is a probability of the disease occurring. So basically, the pathophysiology of this is the basal ganglia and extrapyramidal motor system involvement is kind of like Parkinson's, only opposite, really. We have an excess of dopamine. So the neurotransmitters are deficient in acetylcholine and GABA, and that makes the body produce excessive dopamine. So death usually occurs from infection, choking, and pneumonia. Also in this disease, onset is usually 30 to 50 years old. So when I say opposite of Parkinson's, typically with Huntington's disease, there's what you call chorea, or abnormal and excessive involuntary movements like facial, the extrapyramidal type of movements, face, limbs, and the body are twisting movements. Chorea means like a twisting or a writhing type of movement. It does affect their speech, chewing, swallowing, so they can aspirate. Ambulation eventually becomes impossible because of this excessive movement. They can even develop intellectual decline, and most of them will have a lot of emotional and behavior problems, depression going on with this disease. There's no cure for it. So these people may be put on antidepressants, antipsychotics, anti-chorea medications to help stop that extra movement a little bit, like Klonopin would be one of those. These people also need double calorie intake. Some people may even need 3,000 to 5,000 calories a day, just because all that extra choreal movement is using up a lot of energy. In your book, it does say that psychiatric symptoms are frequently present in the early stage of the disease, and often even before the onset of motor symptoms. So they're not developing these psychiatric symptoms because of the movements necessarily, but it's a disease that is affecting the brain and causing psychiatric problems, plus all the movement from the excess of dopamine. So if you think about Parkinson's with that cogwheel rigidity, it's kind of like the movement starts, stops, and this one is just an overreaction of that movement going on. Death usually does occur 10 to 20 years after the onset of symptoms. Okay, next is Guillain-Barré syndrome. This is the syndrome that you have that questionnaire that you ask people questions before they get their flu shot, and there's the question of, have you ever had Guillain-Barré syndrome? And nobody ever knows what you're talking about when you say that. This is Guillain-Barré syndrome. So anybody who's getting a flu shot, they cannot get it if they've had this syndrome. But it is an acute destruction of myelin sheaths due to an autoimmune disorder, and it results in varying degrees of muscle weakness and paralysis. So this sounds a lot like your multiple sclerosis, except this is an acute destruction of myelin sheaths, where MS is a chronic progressive degeneration characterized by demyelination of nerve fibers of brain and spinal cord. So same thing, only this comes on quickly, and most of the time it does go away, and most people have almost full functioning after it subsides. So there are 3 stages to this disease. The initial period that lasts 1 to 4 weeks, and that's the onset of symptoms. Then there's a plateau period that can last from several days up to 2 weeks, and there's no improvement but no deterioration either. And then there's a recovery period. Could be from 4 to 6 months. It's usually about 28 days in most people, but it could be 4 to 6 months, could even be up to 2 years in the recovery period. The demyelination and the return, I don't think that's supposed to say demyelination, maybe the reconstruction of the myelination, a return of muscle strength. So the cranial and motor nerves are affected more often in this disease. Oh, I guess I forgot to mention one important thing is that this disorder is located in Chapter 60, spinal cord and peripheral nerve problems, so it is in a totally separate chapter than your chronic neurological conditions. So Guillain-Barré, what causes it is unknown. Possible cell-mediated immunologic reaction. A lot of times this happens right after a viral or bacterial infection. So it's like an acute inflammation of polyneuropathy. So Guillain-Barré syndrome is very rare. It only happens 1 in every 100,000 person. The main features of it include acute ascending, which means going down, rapidly progressive, symmetric weakness of the limbs, so bilateral weakness. Maximal weakness is in 4 weeks. So the reflexes are affected. So some of the symptoms: muscle weakness, paresthesias, which is numbness and tingling, dysphagia, difficulty swallowing, inability to control bowel and bladder, areflexia, which means absent reflexes. You can read all about these on 1441. Some other dysfunctions include like facial flushing, diaphoresis, cranial nerve involvement results in facial weakness, maybe some extraocular eye movements. Pain is a common symptom. It's one of the major ones in this, the paresthesia and muscle aches and cramps that occur, and they are usually worse at night. So, as you know, pain gets in the way of many things like our appetite and sleep, so that may be a problem for these people. The most serious complication of Guillain-Barré is respiratory failure. If it attacks them fast and hard enough, it could result in paralysis to the thoracic area, which would affect their respiratory system. So if it does get that bad, they're going to have to be ventilated. And as you can imagine, if they are this debilitated for several weeks, there's lots of issues that can happen, like pressure ulcers, them having atrophy from a lack of using the muscles as they're in bed. So we're really going to have to do a lot of care on them. So some diagnostic tests that we can do. On my PowerPoint it says white blood cell count. I guess you're assessing if they still have an infection or not. An electromyography, but only after 4 weeks, I guess, is it going to pick up the severe muscle weakness. A lumbar puncture is just to assess the cerebral spinal fluid to rule out other causes of all this going on. Mainly, we're going to get our diagnosis from the history and their clinical signs, and they'll be given this. You can look at some YouTube videos that I've posted here of some people that have had Guillain-Barré syndrome, if you like. Sometimes they will even do plasmapheresis on Guillain-Barré people to see if they can help, if that can help with this process. Not on the test, but you might also want to look in this chapter, Bell palsy. That is something that's you might see more frequently. Let me just turn to that. It's on page 1439. So it's an acute peripheral facial paresis of unknown cause. So it affects the cranial nerve, the facial nerve, 7 on one side of the face, and so of course there's symptoms of a stroke, but it's not a stroke. So sometimes, most of the time, this paralysis goes away. You can look at the picture on 1439 of the woman's facial characteristics with the Bell palsies. So a lot of times, this may happen after a herpes simplex virus or a herpes zoster virus, so your shingles viruses and that. So the viral infection causes an inflammation, and that leads to nerve compression and results in the clinical features like this facial paralysis. Like I said, that's not on the test, but that would be something I would look at just in case it's on the NCLEX. Now I just want to briefly touch on assessment of the nervous system, which is your chapter 55. You don't need to go in great detail reading that chapter because we've already gone through assessment throughout the year. So, but if there's anything you don't understand or you need to brush up on, you should look through that. So first, our subjective data that we're collecting are health history, health information. So that's some important information, and that's oftentimes we get most of our assessment data when we're collecting our health history information. Just by talking to the patient, you can assess a lot of their neurological function and their level of consciousness just by doing that. So look at their past health history, medications, any surgeries they've had or other treatments. Do they have any headaches, clumsiness? Have they had any changes in visual acuity? Have they ever had a seizure? Do they have any numbness and tingling? Are they having any pain anywhere? Any personality changes or mood swings? Extreme fatigue or tiredness? Those would all be things that we're looking at with neurologic assessments. Okay, and then our objective data comes with our physical examination that we do on the patient. So what is their mental status and their orientation? Are they orientated ×4, which means person, place, time, and purpose? Do they know who they are, where they are, what time is it, and why they are where they are? So a lot of times we don't want to just put disorientated. We need to know which one of those are affected, if not all or just some of them. Also, with neuro, we're looking at their behavior or mood, their affect. Are they in their thought processes also, and their memory, their short-term and their long-term memory, their level of consciousness. We've talked about that with the Glasgow Coma Scale. You know the different levels of number. 13 to 15 is the maximum functioning. Down to 8 is comatose state. And also with the Glasgow Coma Scale, what are those 3 specific areas that we're really assessing on that? And then with the objective data, we're looking at language and speech. Are they able to speak? Are they having any slurring? So speech is usually a function of the dominant hemisphere. Of the person. I don't think I'm forgetting anything on that. I guess I would go over the different types of aphasia in your stroke chapter. I would just be familiar with like your Broca's and your Wernicke's, but mainly I'm looking at is it expressive aphasia or receptive aphasia or global type. I would just know those differences. More on your objective data that you're collecting. The cranial nerves, if you want to look over that, you don't have to memorize those, like I said, but they do talk about them in the chapter 55, Your Assessment of the Nervous System, page 1299. So there are 12 paired nerves composed of cell bodies with fibers that exit from the cranial cavity. Also, there's a picture on page 1300 of all your cranial nerves, and they're numbered according to the order in which they leave the brain. So 1, your olfactory, affects your smell, your optic nerve, your oculomotor, your trochlear, abducens nerve, your trigeminal nerve, facial nerve, acoustic nerve, glossopharyngeal, and your vagus nerves, your spinal accessory nerve, and your hypoglossal nerve. You could look up some YouTube videos if you want to see how to test all of those nerves, but also that handout that I gave you kind of gives you clues on how to, what each one of those nerve affects and how you would test them. Also, if you're assessing motor function, you want to look at bulk, tone, and the power of the major muscle groups. Look for any hypotonia, like flaccidity, or hypertonia, if their reflexes are spastic, or if their muscles have spasticity. Myoclonus would be spasms of the muscles. Dystonia is impaired muscle tone. Sensory and perceptual status, can they feel touch? Do they know where things are according to space, like their proprioception? And then their sensory is also can they feel the light touch, or can they feel pain or temperature on their skin, or vibration senses? And then their reflexes also. We want to know if they're hyperreflexia or hyporeflexia. Also, if you're not quite sure on assessing the pupils, you might look over that also and just refresh your memory on those, what it means for Perla. These are also just some different types of assessment things. Burdinsky's sign means there's meningeal irritation. If you lift the neck and the hips and the knees flex in response to that neck flexion. And then a Koenig sign also means there's some meningeal irritation. You start with the leg bent, and then when you straighten the leg out, if there's an intense pain, then they have positive meningeal irritation. This last slide just shows some different posturing that occurs with cerebral damage. So it's decorticate and decerebrate. So decorticate is like a flexor positioning, and it indicates problems with cervical spinal tract or a cerebral hemisphere. And then decerebrate is problems with the midbrain or pons. And then, in the lab, when you guys did the Glasgow Coma Scale, it asked with response to pain if there was any abnormal posturing, and these would be the types of posturing that you might see if there's been damage. Okay, that's all for this part 2 voiceover. You guys should do well on your test. Good luck to you.